Again, thank you so much to the VBID Center and to the wonderful speakers we're going to have today. I appreciate this opportunity to share some of the work we've been doing at the Center for Workforce Health and Performance, to hear about the latest and greatest from VBID and from our 2 additional speakers. With that, I'd ask you to advance the slide. The Center for Workforce Health and Performance is an organization that was founded a few years ago, a nonprofit organization, a sister organization to the Integrated Benefits Institute. And we focus on building the best evidence we can and sharing the evidence that others generate around improvements in workforce health and performance. I would welcome any additional comments you might have or questions you might have through the chat window for us as we go through this. I hear other people dialing in still, so please mute your phones as needed, and please feel free to ask any questions through the chat window. We will allow enough time at the end of this presentation to be able to answer many of those questions that you will send in. Please advance the slide. What we'll cover today is quite a lot of information that we're hoping will be engaging to the really wonderful audience that we have for this webinar. This was a very well attended and registered webinar, and we're excited about following up with everyone who wanted to attend but maybe was not able to get in, and we'll make sure that information is posted afterward. What we're going to cover today is define and describe the problem of cost-related non-adherence for patients with diabetes. We're also going to describe and explore the potential role of value-based insurance design in tackling the problem of cost-related non-adherence. And we're going to look at what one organization is doing to enhance access to evidence-based care and to improve patient-centered outcomes. Please advance. Our role in this at the Center for Workforce Health and Performance is related to connecting exactly the kind of evidence that's being generated on multiple fronts around ways of creating value that is more patient-centered and that will result in a wide variety of outcomes that are health-related. And I think you'll see throughout the presentation from our 3 presenters that we have a lot of wonderful evidence that is available out there, and we have a challenge of disseminating it in a way where it will have uptake, getting the incentives right on that, getting the information conveyed in a way that makes sense, and making sure that it represents the values of patients and others who are interested in improving health. Our particular focus happens to be on employee health, and we have a series of frameworks we've developed that connect population health to personalized medicine, and the first framework we released is on diabetes. And that's why we're excited to partner with VBID on this webinar today, and I would welcome you to go to our website to download that framework and welcome any participation. It's a living framework, so we do encourage folks to provide feedback on it. So with that, if you could advance the slide, I'll show you a little bit of what that framework looks like. I don't expect you to read it here, but just so you can see, we're trying to trace what are population indicators around preventing disease through to treatment when folks do have disease, and ways of having earlier identification and treatment for the disease and associated complications. With that, if you could advance the slide. Thank you. Today, we're going to focus really on what's more the treatment end of this framework. So we're going to look, as I mentioned, at cost-related non-adherence to treatment. And we're going to talk about how value-based insurance design can be a great solution for being able to get folks who need treatment in to have evidence-based, high-quality treatment earlier than they might have in the past, and with less barrier. And that's what would make it earlier. So with that, if you could advance. We will address many questions. I'm sure that there are questions out there that our speakers will address just by virtue of their presentations. Again, I would welcome throughout the presentation to ask any questions you might have in the chat window. We will come back at the end. I will help to field some of the Q&A. But some of the questions that we would like to think about are, how is value defined and what should investors think about when they're looking at value that's produced, making sure that health becomes something we really, really focus on. What outcomes of care might be most important to consumers? That's a particular interest to us as we work on our PCORI-funded projects, the Patient-Centered Outcomes Research Institute projects. What are the biggest opportunities for improvement in terms of quality care and equitable distribution of outcomes? What's barriers to excellent care and how is that defined? And then what role can different stakeholders play in supporting excellent diabetes care? If you could advance with that, I'm excited to introduce our next speaker. And Dr. Frank Wareham is at the Harvard Medical School and Harvard Pilgrim Health Care Institute. And I'm delighted to have him present today. Thank you.
Okay, great. Thank you so much, and it's a real pleasure for me to get to present to this audience. As we're just hearing, value-based insurance design is an important topic and one that we have focused on through our studies of high-deductible insurance for about a decade now. And so I lead a group called the Division of Health Policy and Insurance Research, and we try to do highly rigorous studies about health policies to try to really get at the truth of what these policies are doing to patients. So I'm going to talk today about high deductible insurance, diabetes patients, and and value-based incentives for those patients. So many of you may know how common high deductible insurance is, but 40% of all U.S. adults have high deductible health plans, and the red and light red parts of that pie chart show the 40% of the U.S. adult population that's enrolled through high deductible insurance, most through their employers and some through the directly purchased, like through the state exchanges. What are high deductible plans? These have potential out-of-pocket cost to patients of $1,000 to $7,000 per year, but selective preventive services are exempted from the deductible. This was happening to some degree before the ACA and a lot of the high deductible plans that we study, but the Affordable Care Act mandated that services recommended by the USPSTF are A or B, highly recommended preventive services are exempted from the deductible. So these plans are not only prevalent, they're growing rapidly. You can see from 2006 to 2017 the strong growth in the employer-sponsored market, with now over 50% of workers having these high deductible health plans with a deductible of at least $1,000. So why study diabetes patients in high deductible health plans? Well, this is, I copied down here a letter that a woman wrote to me actually before we'd even started some of our diabetes research, because she had sort of heard or seen on the internet that we were going to study high deductible insurance. And so she wrote me a letter about her personal situation. She actually asked me to share it. Her name is Jane. And this is what she wrote. She said, "My husband is now working again, but once again his latest company offers only one insurance option, which is a high deductible health plan with a $4,000 deductible. Because of this and our financial situation, I am for the first time in my 48 years of diabetes reusing needles up to 4 times, limiting the number of test strips to 1 or 2, cutting back on insulin, and I have not had an appointment with my endocrinologist in well over a year, and I have no idea where my A1C is at." So why study diabetes and high deductible insurance? Well, these are patients who are going to be facing some of the highest costs because there's a great need for care, a great need for frequent interactions with the healthcare system. And so this is a population that might be at particular risk. And research going back to the 70s and 80s through the RAND health insurance experiment did show that patients who are low income and had high sickness levels were at greatest risk of of adverse outcomes under high deductible or high out-of-pocket cost-sharing insurance. But there's interesting features to modern high deductible health plans where there are services that are carved out. So we're able to look at both high value services that are carved out and not carved out. In other words, high cost and low cost high value services. So I'm going to share some of those results today. Before I do that, this is the study design that we use. Again, we try to use very rigorous study designs that will demonstrate whether or not an effect of a given intervention occurs. And this is a before-after study design. And what it's showing there is that we studied a population that was in a traditional low-deductible plan for 1 year during that baseline period. And then they had an employer-mandated switch into high-deductible insurance. That the lock indicates that their employer only offered a high-deductible plan the next year. And then we followed them for up to 2 years. And then we compared that group to diabetes patients who were in low-deductible plans during that same period, and their employers only offered low-deductible plans for the next 2 years. And we call that time of the high-deductible switch the index date, when they switch from low to high deductibles. This study came from 45 million members across the U.S. in data from Optum, which represents a large health insurer, and the data come from 2003 to 2012. So the next slides are going to show some of the results from the study. And this first slide is really showing both the intervention, in a sense, and what these patients were exposed to. So this is showing monthly out-of-pocket costs among diabetes patients, again, for the 1 year before they were switched to the high-deductible plan and the 2 years after. So I show this to indicate the level of cost-sharing increase that these patients actually experienced. And so it was a $400 approximately increase from before to after over those 2 years, and that's about a 27% relative increase in their out-of-pocket costs. And that vertical blue line shows the time when this group switched from low deductible plans to high deductible plans, and that sawtooth pattern is really because these diabetes patients end up hitting their deductible. You can see partway through the year, and then they spend less because they've hit their deductible, but they've spent a lot at the beginning of the year. So what did we find? What were the effects of high deductible insurance? This next slide it just poses that question, really. We wanted to study, again, care without value-based cost-sharing reductions, and we've also moved towards studying care with value-based cost-sharing reductions. But we want to know what happens to high-value, high-acuity care when diabetes patients in high-deductible plans face high out-of-pocket costs for their care. And this is some of our results. So to orient you to this slide, I talked earlier about previous research that fairly intuitively, as you can imagine, high-income members have less challenges when facing high out-of-pocket costs, and low-income members will obviously experience more challenges. And so we divided our results into a high-income group or a low-income group, and that's what this is showing on this slide. Where the high-income group on the left, we were measuring, in this case, visits to the outpatient for outpatient visits for acute preventable diabetes complications, and the high-income group did not experience a delay in time to these visits. These are sort of time to event plots, and these are showing that the high-income group did not experience a statistically significant delay, whereas on the right, the low-income group did experience a delay. And you can see that red line being under the green line means it took longer for those low-income patients to present to their outpatient facilities when they had a diabetes complication such as cellulitis, pneumonia, urinary tract infection. Those were sort of the most common of these diabetes complications that we studied. Then we wanted to know, well, we see these delays in outpatient care for diabetes complications after patients are switched to high-deductible insurance. So does that have any apparent adverse effects? And that's what this slide is trying to show. So again, the high-income group on the left there did not experience any increase in their complication visits to the emergency department. But on the right, these same types of visits, again, cellulitis, pneumonia, urinary tract infection, things that could be prevented with good care and ready access, those actually increase. So that red line, this is a cumulative rate, that red line going up above the green line. The red indicates the high deductible group, the green the control group. That indicates that over those 2 follow-up years, the high deductible group experienced more emergency department complication visits for complications of diabetes. There's actually a very large relative increase of about 22%. And then we also wanted to see what were the costs of emergency department visits. So we subset. This is now a broader category of emergency department visits. So all emergency departments that are classified as high severity by a certain classification algorithm that you can use in health insurance claims data. So when you take all high severity emergency department visits, we wondered whether those would be more expensive, less expensive, or the same among patients after they switch to the high deductible plan. The idea being that if patients are delaying care, then once they show up to the emergency department, they might be sicker, and we might see that they're sicker in the form of increased total costs. So again, on the left is showing our overall population of commercially insured diabetes patients switched to high deductible plans, and the right is showing the low income subgroup in 1 year of follow-up. And you can see that before the switch, groups are similar. After the switch in year one, that red line goes above the green line, indicating the higher total costs in the low income group of diabetes patients switched to high deductible insurance plans. And as another sort of outcome that could indicate adverse effects of the high deductible plan, we also looked at hospitalization days that followed high severity emergency department visits. The idea being that if you have to stay in the hospital longer, it could indicate that you're sick. Our claims data are good at looking at certain types of services, but it's a bit harder to find what's an adverse outcome. But longer hospital stay is genuinely agreed to be a pretty good indicator that someone is sicker. So that's why we studied this. And you can see, again, the overall group, no effect. But once you subset to the low-income group, a very large increase in hospitalization days. So before the switch to high deductible insurance, that's the baseline. There was no difference when both groups were in low deductible plans. And then after the switch, when the high deductible group was paying a lot more for services in general, they had greater increases. They had a greater increase in these hospitalization days after high severity emergency department visits. So to summarize, high out-of-pocket costs for acutely needed services among low-income diabetes patients were associated with delayed care and apparent increased adverse outcomes and related costs. And interestingly, and this surprised us, the high-income diabetes cohort was not particularly affected. So, this is we see this as a policy opportunity not only for value-based cost-sharing exclusions, but what we've called population-tailored health insurance designs, where there might be a subset of particularly an employer's population that might be at greatest risk, and insurance designs or mechanisms could be implemented to based on evidence to specifically sort of target those at-risk populations for more generous coverage, or something like health savings account contributions that are preferentially given to one type of population in a sort of a zero-sum way, so that you don't have to increase the amount of money, but the funds can be shifted to at-risk patients. So that is all I have, and I'd be very happy to discuss our results in the Q&A session, and if anyone has further questions or comments, be very happy to discuss by email or any other form. But thank you very much for listening to our research.
Frank, thanks very much. Really great setup for demonstrating that diabetic patients are not, through their insurance products, not getting the care they need. I hope all of you could see the slide in my smiling face. This is Mark Fendrick. I direct the Center for Value-Based Insurance Design, and as we got off to kind of a little bit of a rocky start, I wanted to make sure that everyone knows that we are doing some live tweeting, providing supplemental resources for those of you who might be interested in learning more about the topic of cost-related non-adherence in diabetes and the VBID solution. You also can see our VBID Center Twitter handle at the bottom of this slide. I encourage our students to maximize our Twitter following, and you can make them all happy if you would pick up your cell phones or computers and follow the VBID Center on Twitter. So, Frank, I very much appreciate you kind of setting me up to talk about why value-based insurance design might be one potential solution to the issue of cost-related non-adherence problems, and to level set and kind of speak quickly to make sure Josh gets adequate time to tell us what's happening in the state of Minnesota. I think just about everyone on the call knows that we're spending more than we should in healthcare, but not getting what we need to be getting in terms of individual and population health. And while most of the policy discussions are focusing on payment reform and how clinicians, myself, and delivery systems and accountable care organizations are moving from volume to value, we also need to engage patients to hopefully fix some of the issues that Frank so well articulated. The issue at hand, however, and we've been dealing with this for quite some time in the VBID Center, is that the most predominant type of consumer engagement tool are not population-based or more nuanced, as Frank would suggest, but the current tools are one-size-fits-all cost sharing, and the fact that our patients are being asked to pay more for all services, both high and low value, and this skin in the game concept is the most common lever to change consumer behavior. And we know we asked Frank to get his slides in a week ago. Some of you might want to look at this month's Health Affairs and a paper out just yesterday, Frank, so we did not count on you to change your slides then. But the Health Affairs reports that 85% now of covered workers face a deductible before they could use chronic disease services. So I thought 50% was rather high. And as most of us who've been looking at the impact of cost sharing know, that we used to be worried about co-payments and co-insurance, but what keeps us up at night is the fact that now the tool to lower healthcare costs is not allowing any access to any service before a deductible is met. There's a wide range of deductibles, as all of us know, but it's extraordinarily interesting that other reports from the General Accounting Office and elsewhere say that half of Americans don't even have $400 in the bank. And there's studies of people now who are not high income and high deductible health plans who know when they enroll, like the patient that Frank showed the letter from, that they will not be able to get the care they need, especially for those folks who are socioeconomically challenged or have chronic diseases like diabetes mellitus. So the motivation for Mike Chernow and I, going on our almost third decade, and the primary vision for the VBID Center is to figure out ways to alleviate cost-related non-adherence. And I think most of you know that cost sharing is continuing to rise. And we, like Frank, has kind of summarized his body of literature and elsewhere. A great quote that my friend Annie Allison, who's on the phone, has heard me say many times. My mother said, "I can't believe you had to spend $1 million to show that if you make people pay more for something, they'll buy less of it." So Frank's studies are really the cornerstone of what we know about high cost sharing in diabetes, although there are several studies now out there showing my mother was right, and we've been trying to identify tools to make sure that patients like Frank's are able to afford evidence-based care that we know will improve quality and length of life, and in certain circumstances actually lower aggregate healthcare costs. So this is across the board, not just diabetes, but we've seen some diabetes-specific studies that show that even though we've had great expansion of coverage in this U.S., primarily through the Affordable Care Act, the rate of individuals basically telling us in surveys that they have difficulty affording their prescription medicines, like medicines to lower their blood sugar, their cholesterol, or blood pressure. In the case of diabetes, 1 in 4 will self-report. I actually believe that number is quite higher because many people are willing to give other reasons to why they're not taking their medicines, or they might be splitting their medicines or taking them less regularly and prescribed in a way to make them last longer. It should come as no surprise that, as Frank's work has clearly shown, that if you focus on those people who are lower income or chronic diseases, they are the folks who are most taxed by these high deductibles, high cost sharing, and co-payments. And we are, excited to see, as Kim said, a rising body of evidence to suggest that we may be able to pull some population-specific levers to allow them to get the care they need. And our flagship condition in value-based insurance design, since we started talking about this in the last century and the VBID Center launch in 2005, has been diabetes. As you see from this rather complicated slide, when you compare diabetics who are in the bluish color compared to those who don't, the number of people who reduce medication to save money in this C2C survey suggests that the problem is likely higher in populations with diabetes mellitus compared to those who don't have the diagnosis. And we've been working hard not only through the peer-reviewed publications, such as the one you just saw there in Frank's. We like to say at the VBID Center we published and we still perished, and been working very hard to get the word out to the lay press. And we would ask all of you on the phone to kind of extend these messages to make sure that people are aware that diabetes is one of the many chronic conditions now because of the policies. moving patients to one-size-fits-all or blunt cost-sharing instruments like high deductibles, that the number one cause of medical bankruptcy in this country, I think all of you know, is healthcare costs. And I'm also sad to say the number one driver for Kickstarter campaigns or other online fundraisers is also medical necessity. I really hate to say it, but say it quite often, that I really don't like the fact that my patient need to have a bake sale to be able to get the evidence-based care to take care of her diabetes. So part of the solution, I think many of you on the phone, and I look at the names of the attendees, healthcare costs and drug prices in particular is a very hot topic. That is above our pay grade at the VBID Center. I like to show this slide as one of my favorite tweetable sound bites. Ron Cornell, I know you're tweeting out there. Americans do not care about healthcare costs. They care about what it costs them. And while the broader macro issues might be in the purview with some of you on the phone in terms of prices, I think dealing with out-of-pocket costs for evidence-based services is something we can more rapidly get our arms around. We have broad multi-stakeholder support, for which I'll show you later. And those of you who looked at the Trump administration's blueprint on access to drugs, you'll see right on the cover it not only talks about drug prices, but it actually says and programs to lower out-of-pocket costs. So we are getting traction in getting this message to high-level policymakers, understanding that there are two really important issues. One is the aggregate price of medical services and drugs, but we've been focusing on is the portion of the high-value services that are paid for not by the insurance plan or the employer, but actually paid for by the patient. So we have advocating, as many people know, for quite some time of the idea of value-based insurance design, that instead of setting consumer cost sharing like a sledgehammer, to do it instead like a scalpel, to identify specific populations and services, identify those high-value services such in diabetes, which would be medications, eye and foot exams, nutrition counseling, vaccinations, et cetera, and make them as easily accessible as opposed to hard, what we see now. And the good news is that we've been doing this for a long time, and the VBID idea has been successfully implemented by hundreds of public and private payers. And what's, I think, really helped us move this idea along is, A, it's intuitive, B, it's not very controversial, and probably the biggest thing that's moved value-based insurance design along is its rare bipartisan political support, let alone the support we have received from organizations like these on this slide, some of which we stopped adding to, but it's one of those rare situations you see management and labor on board, as well as the health plans and the pharmaceutical companies, as well as the providers like the American Medical Association. Can I ask all of you to put your phones on mute, please? So a lot of people out there, and I'm going to kind of summarize 10 years of work like we asked Frank to do. How does value-based insurance design actually work in terms of increasing medication adherence and impact on spending? We were fortunately able to publish an updated review of the literature on VBID programs and medication in the July issue of Health Affairs, and what that showed, that 21 studies showed a range of medication adherence improvement. That depends on the baseline and the incentives that were provided. But the really important message in terms of moving VBID forward is these increases in adherence, and most of the studies included in this review included diabetes, was associated with no effect or impact on total healthcare spending. So you got the improved health at no incremental cost, which is a very important driver to many of the public and private payers that we're working with. I'm just going to quickly go through a couple slides about those of you who are learning about VBID for the first time, and it may be hard, it may be intuitive, but there's inertia to overcome. I think it's very important to remind some of you in the audience that even though you think you're not doing VBID, that every private and commercial payer in the country has implemented some part of a VBID plan through the VBID provision in the Affordable Care Act. which mandates that all non-grandfathered plans cover without any cost sharing any service with an A or B rating from the U.S. Preventive Services Task Force, all the immunizations recommended by the ACIP at the CDC, and additional preventive care and screenings for women's health and children through the Health Resources and Services Administration. So although many of you may not think you're in health plans that have value-based insurance design, I would guess that 2/3 to 80% of you on the phone have received some expanded coverage of preventive services because of Section 2713 of the ACA. And I like to tell people, as I'm going to try to speak quickly, Obamacare is a 900-page law. All I ask you is to like 1/2 of one page, which is the 1/2 of one page the VBID Center helped write. And the very good news in following public support for removal of cost-sharing preventive services in the fact that every survey ever done of the ACA has put in the elimination of out-of-pocket costs for preventive services in the top 3. And the very good news is Section 2713 was preserved in all of the 40-plus repeal and replace plans that moved through the Congress 2 years ago. We've also made some strides in adding value-based insurance design to the Medicare program. The Medicare Advantage VBID model test is the first demonstration ever that allowed disease-specific cost sharing for specific services. Importantly, diabetes is one of the conditions that's specified by CMS, has been included in some of the demos underway, including some of those that are planned to launch in 2019. I like to point out that the demonstration was started by the Obama administration and was actually expanded by the Trump administration. And as far as we know, it's the only demonstration that actually was expanded on the new administration that was existing already. We've also made some implementation of VBID in the TRICARE program. There's one of our great Hill champions, John McCain, who helped us write legislation to allow VBID principles in the TRICARE program. I'm going to close quickly, kind of tying Frank's presentation to the solution we're really trying to look at and for. In the fastest growing type of health savings account high deductible health plan, which I believe 29% or so, if you look at the Kaiser Family Foundation survey, Americans are enrolled in these. This is a very attractive and the fastest growing type of health plan. For patients like Frank and patients like mine with diabetes, they are very much hindered by the fact that current legislation does not allow these HSA high deductible health plans to allow pre-deductible coverage for any of the high-value services that I mentioned and that Frank noted. So we have been working both with the Trump administration and Capitol Hill to introduce legislation to allow health plans the option to cover things like medications that lower blood sugar, cholesterol, and blood sugar, as well as those services like eye exams and foot exams that are currently not allowed to be covered on a pre-deductible basis. And here are the bill numbers now. I think that any of you working in an organization with a government affairs person may want to look into this if you're interested in potentially pulling a lever that might mitigate some of the issues that Frank articulated in his research. So the last thing I'll say very quickly, I know it's lunchtime for those of us on the East Coast. For Kim, it's still breakfast. But many of you are focusing on the move from volume to value with payment reform initiatives. I call that peanut butter. I believe we are actually moving from volume to value on the supply side or the peanut butter side. However, my view is that with the growth of these high-deductible health plans and the lack of nuance in terms of what is covered pre- and post-deductible, that what's happening on the patient side or the demand side that I call jelly is actually pushing our patients away from volume to value. That it's my hope that with some of these policy levers, with VBID one of them, that we would actually have a situation where it would be easy for clinicians like Frank to do the things that's right for his patients, and also easy for his patients as opposed to hard to do those things. And we do believe that there are peanut butter levers like payment reform and consumer levers like value-based insurance design that would bring us to this situation that I hope, really hope, would kind of transform the healthcare conversation in this country from how much we spend to how well we spend. So I like to leave this, my favorite quote as I turn it over to Josh, if we don't succeed, then we will fail. And I'm really pleased to have Josh following us, because while we have been speaking about value-based insurance design for a very long time, I saw that my colleague Jill Berger, who was at Marriott, the hotel chain, who implemented VBID now, it seems like 2 decades ago, but we're still the tortoise in the healthcare reform race, and realize that while the idea might be easy to explain for me, it certainly may not be easy for a public or private employer to move forward. We have folks from the state of Connecticut on the line, the city of New York, but today I'm really pleased to turn the telephone over to Josh Fangmeyer, who will tell us how they move VBID forward for diabetic patients in the state of Minnesota.
Great. Well, thanks, Mark, and thanks to the VBID Center for hosting today's webinar. We're just really excited to be able to share the experience that we've had so far with implementation of VBID in the state of Minnesota and with the State Employee Group Insurance Program. So I'm the research director at CGIP, and I'll get into my slides here. Okay, so a little bit of background on the State Employee Group Insurance Program. We're the largest group employer purchaser of healthcare in the state of Minnesota. We cover almost 130,000 covered lives, and primarily we cover our state employees, their dependents, separated workers who have access to COBRA, and early incentive retirees who are primarily in law enforcement and corrections. Notably, we don't cover traditional retirees. We have them in a separate pool, so we don't do as much coordination with Medicare as some other public employers have to do. We're a completely self-insured program, and we have 3 medical third-party administrators and 1 pharmacy benefit manager. And more than 8 in 10 state employees in Minnesota are represented by a labor union. And one of the things that makes CGIP a little bit different from some other large employers is that we operate a tiered network where we tier primary care systems across Minnesota at one of 4 different cost levels, and we've been doing this since 2002. And I believe we're one of the oldest tiered network systems in the United States. And notably, for the purposes of today's presentation, we cover about 6,000 adults who have diabetes. So we've been doing diabetes programming of various forms at CGIP for the last several years. We started out in 2013 with a medication therapy management program that had a big focus on providing pharmacist consults and those sorts of services to members who had multiple different types of medications, and then also discounting the out-of-pocket costs for diabetes medications, hypertension, and other related drugs. While this program was of great value to members who were enrolled in it, one of the challenges that we had with that old model is that only about 10% of our adults who had diabetes were actively enrolled in the program, many of whom had a hard time hearing about it or found some issues with getting enrolled or getting started in the program. And so that really helped to inform our program decisions going forward. And then in 2015, we implemented a new diabetes prevention program. It's an online program through our vendor, Omada. And for the last few years, we've been having more discussions with our labor union partners around the concept of value-based insurance design, and really trying to come up with the types of conditions that we should focus on, at least to get this implemented in the short run. And we ended up landing on diabetes, and for a few reasons that I'll get into in a minute. But the program that we ended up developing is called Advantage Value for Diabetes, and this launched on January 1st of this year. And it actually absorbed that old medication therapy management program. And that's where we started at today. So we don't have a lot of results to share. This is going to be mostly a story of our implementation process. So the reason that we ended up with diabetes in particular is that there's just a clear standard of care, and there's long established quality measures in the state of Minnesota. It's easier to measure the gaps in care compared to some other chronic conditions that we were considering. As I mentioned, we have 6,000 adults, so we have a large enough population to be able to run this program with, to understand its effectiveness. And that diabetes typically can develop early enough, and especially with a state employee population like ours who tend to stay with the state for a long term of service, that we feel like as an employer we can really make a difference in terms of their clinical outcomes. And so the way we landed with the program today is that the Advantage Value for Diabetes is for adults who are 18 and over with type 1 or type 2 diabetes. And as opposed to the old medication therapy management program, it's fully integrated into our main program, the Minnesota Advantage Health Plan, meaning that there's no separate enrollment requirement. Members automatically get this benefit just when they sign up for their regular health insurance coverage. The way the claims are administered is qualifying medical care needs to be paired with a diabetes diagnosis. And for the nerds out there, I included the ICD-10 codes if that's of interest. And for qualifying prescription drugs, they must also be paired with either having a medical diagnosis of diabetes or having a qualifying fill of anti-diabetic medication beforehand. So here's the actual benefit design that we ended up implementing for the AVD members. So as I mentioned at the top, we run a tiered network, and so our members are at one of 4 different cost levels. But because we steer members in this way to more cost-efficient clinics, 90% of our members are in clinics that are either at cost level 1 or cost level 2. So that's the top 2 rows here on this table. And for those members, they're paying really no out-of-pocket costs for the vast majority of their diabetes-related care. So for office visits that are related to their diabetes evaluation management, they're paying $0 copays. They're not paying any out-of-pocket costs, no coinsurance for related lab tests, and test strips are also at have no coinsurance as well. And some of the reasons that we ended up implementing some of these changes is that we really wanted to encourage members to have more access to these high-value medical services. We were coming from that MTM program that had emphasis on prescription drugs, so we wanted to build on that prescription drug program while also enhancing it with these medical services. And so on the office visit piece, I do want to mention that this includes both primary care and specialty care, including diabetic retinal eye exams and dietary consults. And on the office visit piece as well, you'll notice in cost levels 3 and 4 that we do maintain some copay amounts of $30 for cost level 3 and $50 for cost level 4 in order to continue to encourage members to go to those high-performing care systems. And on the prescription drug benefit side, we did something very similar where we're discounting across the board but maintaining some amount of out-of-pocket costs for preferred branded and non-preferred branded drugs. And notably, we're also including depression drugs as well as the diabetes, cholesterol, and hypertension drugs, which are traditionally part of VBID benefit designs, just because we saw enough co-occurrence between diabetes and depression that we thought adding in depression would help with the outcomes for our diabetes population as well. So when actually putting this benefit design together and getting it out to members, we really wanted to emphasize communication and really trying to drive people to make sure that they're getting the right information at the right time. So we launched a separate web page on our website that included links where people could get plain language descriptions of the benefit design. They could find the eligible drug list so that they could look up their medications to see if they were going to be covered under this program or not. We have a very detailed frequently asked question document, and then we also made it available for members to submit questions that we could use to develop our FAQs as we went along so that members were able to get all the detailed information that they really needed. And then along with that, there's the vendor communication piece, and it's having the right information for your vendors to be able to program out the benefit design and get that to work as you intend, and then also specifying all of the codes and drugs and how exactly you want them covered as well. So now that we have the program actually implemented, we are already thinking about next steps, and at the top of that list, and I hope Mark and Frank will really appreciate this, is an emphasis on evaluation and really thinking about what are we seeing in terms of outcomes from this program, or what are some of the things that we should be looking to keep an eye on over the next year or two as this program, as we get more experience under it and are able to understand its effects on our diabetes members. So when it comes to evaluation, we're looking at, like, for the services, these high-value services that we've targeted, that we really have emphasized the reduced cost sharing for. Are we seeing improved use on those services? Are we seeing improved drug adherence for prescription drugs? Are reducing these adverse events that Frank talked about, the ED visits and admissions from diabetes complications? And overall, what are we seeing in terms of our cost trend? We really are, in terms of like looking at the value of the program, looking at more of the member outcomes and the improved clinical care, but cost is always an important consideration for all employers. And then we're also looking at, what other chronic conditions or populations could best be served by VBID under our program. Are there particular populations that maybe have more gaps in care that we think are amenable with a VBID style of implementation? And what are our opportunities to connect to provider quality? Minnesota is fortunate among some other states that we have some long-established quality measurement efforts. And one of the quality measures that's been around in Minnesota the longest has been looking at optimal diabetes care. And so we really do want to explore this relationship between, for our diabetes members, are there ways that we can help steer them towards higher performing providers when it comes to the way that they treat their members with diabetes, their patients with diabetes, and make sure that they get the right care at the right time. So those are opportunities that we're really looking at for consideration in the future. But from our perspective as an employer, I think we do have some advice or considerations that we would want to share with other employers who may be thinking about implementing some other type of VBID implementation for diabetes. First is to really identify, what are the opportunities and the gaps and ways to boost adherence for your population. You should really look to your TPAs and your other vendors who are providing you data to see how your population compares to their benchmark populations, to see what gaps there are and what ways there are to do better, and how much of that can be alleviated by a VBID implementation. And how much do you want to discount cost sharing? Do you want to move towards $0 copays? Do you want to maintain some copay amounts? There's lots of considerations to think through with those ideas. And then the next bullet point really gets into, do you really want to design this all yourself? Unfortunately, we're a large enough office where we had the capacity to really be able to design the program here in-house, and then also rely on some other clinical experts who were able to give us some input. But we were really able to manage this implementation more internally. But if you don't have that capacity, you may need to look towards your carrier to develop a product, or maybe they have a pre-developed product that has a VBID design that you may look to purchase. With the enrollment process, do you want to do something more like what we did, which is more of an auto-enrollment model of just putting people directly into the plan? Or other employers, such as the state of Connecticut, had separate plans, separate VBID design plans that during open enrollment, their employees had the option of enrolling into. So that's another consideration. And then it's vendor integration, which is always among the most difficult tasks with getting a program like this up and going, is figuring out what are all of your vendors, your health plans, your PBM, the other parties involved, what are they all capable of doing programmatically with how they administer claims and making sure that the benefit design works as you want it to. And then are there opportunities to connect this program to your wellness offerings or things like that that can help kind of provide a more comprehensive program for employees. And then finally, our biggest consideration that we want to emphasize is that it's just critically important to communicate clearly to your employees, your vendors, your partners, whether it's the C-suite, whether it's labor leaders, so that they clearly understand what the intent of the program is, what the expected outcomes are, and what you're really trying to get out of an implementation like this for a program for diabetes. So with that wraps up my comments, and definitely look forward to any questions that we can cover. Thank you.
Thanks, Josh. Kim, are you still on the line?
Yes. Are you able to hear me?
We can beautifully.
Oh, sorry about that. Okay. Thank you so much, everyone. Really appreciate it. I've been looking through all the questions coming in through the chat window, and I think I've sort of summarized a number of them in one behemoth question, and welcome any of the speakers to chime in on this. I have a feeling, Mark, hopefully you'll chime in. It seemed that many of the folks who sent in questions through the chat were interested in the feasibility of implementing a population-tailored insurance design, and are particularly interested in implications for payers and employers. regarding these disease and income-specific pieces, how the practicality of implementing that, how to do that. I think Josh spoke to some of those questions in his last slide, but some practicality on where to go to start to implement those things. And then relatedly, are there any global comparisons to VBID, especially in light of big differences in pricing? And so do those need to go in tandem, sort of the peanut butter and jelly? I'm just throwing it out there. Mark, do you want to take a stab at it, or any of the other speakers?
Sure, I'll start and then turn it over to Frank, who could turn it over to Josh. So you did a great job summarizing the questions, which has really been interesting for me, in the fact that there's been this broad support of value-based insurance design, Kim, and this is one of the members of our advisory board. But while the uptake has been slow and steady, it's been nowhere near as kind of what we had hoped it would be. Thus, we've been called a tortoise in the healthcare reform race. So while the idea is somewhat straightforward, why I was so compelled by Josh's presentation to even do things that seem so obvious are not so easy. So one thing I could say is that when we started with this, it was rather hard, and the champions, like I mentioned, Jill Berger and Pitney Bowes and the municipality of Asheville, North Carolina, they had to push really hard on their pharmacy benefit managers to allow these nuanced benefit designs. And then they had to push even harder on their third-party administrators and their plans to say, it should not be very hard for you to be able to make it easy for my diabetics to see the ophthalmologist or the podiatrist. And we've been, slow and steady and focusing on key conditions and to have seen some very significant steps on the drug side, and now more and more momentum, particularly around the MAV demonstration on the services that are not. So I'm very hopeful that the information provided here, a condition-specific one, will actually allow more employers like the state of Minnesota to pick at least one condition, and maybe be like the state of Connecticut and pick 4 or 5, leading to maybe 10. So start with the drug piece. I think it's straightforward. Most PBMs would do a value-based formulary similar to what Josh said, that's disease-specific, and then try to align the other services through the spectrum of care that are also designated as quality metrics. I will say, as we hit the top of the hour, I apologize for a little late start. We will be on the line for 5 minutes or so to take some, hear from the comments from Frank and Josh before Kim signs us out.
Okay, Mark, I'll take it from there. This is Frank Warham. It was also enlightening for me to hear the challenges that Josh mentioned. My academic department is also affiliated with a health insurer and Harvard Pilgrim Healthcare, and so I guess I have a bit of knowledge about some of the challenges that go into creating value-based designs, and partly that's why I sometimes emphasize something like a health savings account, because and I'd be interested in others' thoughts about that, especially the benefits managers. But my sense is that those contributions, there's nothing preventing those contributions from being preferentially given to low-income workers, or the hourly workers or something like that. And so again, that's out of my range of specialty, but that seems like a nice way to take funds and give them people that evidence shows needs those funds the most. I've also talked to employers that will preferentially enroll their lowest income workers in more generous plans and offer higher deductible plans to other workers or higher income workers. So I think this is a great discussion. I'd actually be really interested in hearing about feasibility of some of these ideas, because I'm mostly on the academic and research side. But I'll leave it there and hand it over to Josh, because I know we don't have a lot of time.
Yeah, I think feasibility is really a key word, for employers who are trying to implement a program like this. When it comes to trying to have differentiated HSA contributions or benefit designs for people based on their income level, I think that's ideal, for employers to be able to do that. I just think when the rubber meets the road, the implementation challenges of getting it to work well with their payroll systems or everything else that they would need to be able to have run smoothly is just it's a major. It's more of like an IT challenge for them, but that is certainly a barrier. I wanted to bring up, though, on the TPA side, I would say I think something that's helped TPAs the last few years has been the requirements of implementing preventive services with no cost sharing for their full business. And I think that there are ways for employers who are looking to implement special VBID designs to leverage that previous work. You know, now that health plans have to be able to adjudicate claims based on medical diagnosis information and the age of the member and all these other criteria that's required to administer preventive services with no cost sharing. And they can also leverage that to be able to do more nuanced things around chronic conditions as well. At least that's been our experience so far.
Thanks, Josh. I hope this is not, I'm not the only person who wants to go a few minutes past one, but I'm somewhat Tiggerish in the discussions of value-based insurance design. I will say, to add to your point, Frank, is that there have been a fair number of employers who've decided to limit their VBID subsidies for high-value services, particularly in diabetes, to lower-income employees or certain subsets. And our colleague Bruce Sherman, who's been looking at these issues for quite some time, had an editorial on this exact topic in the American Journal of Managed Care. So, and given that your work and the work from the Aetna study of reducing cost sharing completely for post-heart attack patients did in fact show that almost all of the benefit of the VBID program was incurred in the lower income enrollees, and in that population the VBID program was actually cost saving. So, and this is, as we know, what many public and private payers are looking for. My last point, Kim, before turning it back to you is I don't think many of us think about the federal government and the Medicare program as a leader in this space, but in addition to the Medicare Advantage value-based insurance design demonstration, the Trump administration in June changed one of the longest-standing rules in the Medicare program called the uniformity rule, which was when Medicare was passed, every Medicare beneficiary had to have the exact same benefit design, which is in direct contrast to the VBID idea of targeting and clinical nuance. As of June, Medicare Advantage plans are now allowed to provide condition-specific supplemental benefits. While it's not as far as we had hoped, you can now do many VBID things in MA plans regarding lowering cost sharing for providers and services, although this particular first pass of the amendment to the uniformity rule did not include drugs. So for the programs that want to see lower cost sharing like Josh's for drugs in addition to A1C testing and eye exams for diabetes, you'd have to do this through the demonstration, but you could get a fairly far way with this major change in Medicare regulations.
Great. Thank you. Thanks, everyone. I'd say the evidence is pretty clear, the evidence presented today as well as past research that population-tailored insurance designs are definitely something that we ought to be implementing and learning from that implementation. So moving into implementation research and trying to understand the feasibility of these plans and sharing where it's working and where it's not. And I'd say probably a big challenge is going to be understanding what we mean and how to define population-tailored. We've talked about conditions. We've talked about income. Certainly understanding what a livable wage is in an area will affect the ability of someone to utilize that income toward a deductible or other costs. So I'd say let's take that next step and start sharing our thoughts and further questions and examples of, concerns we have and where it's working, and sharing more examples like Josh's. And Mark, continuing your leadership, and Frank, continuing to do the great research you're doing. I'd welcome folks to continue sending questions they may have or comments to the VBID Center. I believe their email's been sent out several times. They'll also follow up to make sure you can see on the slide right now where to get it, but also to make sure that everyone has access to the slides as well as the recording of this webinar. And we welcome your feedback, and we look forward to doing more of these kinds of events going forward. So thanks to everyone for your time and for your participation.